Hi, my name's Howard Stupak. I'm at the Albert Einstein College of Medicine. I'm fortunate to be there. And today I'll be doing my talk on the topic Rethinking Rhinoplasty and Facial Surgery. And we're going to get started. First, disclosures. I have intellectual property and royalty related to the Medtronic ALAR device, which I briefly show in slide 85, but otherwise do not mention today. Only mention it with other devices. I have stock in some other companies, and I'm the author of a book that was just published from Springer with the same title as the presentation, and you can see this book for a lot of the content. Today's objectives are to show how an all or nothing approach to the nasal airway and aesthetics is viable, especially for a general otolaryngologist, because you have all the skills required, despite easy choices of minimally invasive surgery. Number two, show how the facial skeleton is the root cause of septal deviation, deformity, and obstruction. But most importantly is number three, how differentiating between nasal breathing and mouth breathing and nasal obstruction from nasal underuse is so critical to our field, otolaryngology, and how this affects outcomes. So why are we rethinking anything? Shouldn't we just be happy with what we have? Yes and no. We've achieved wonderful things, but we're also in a point of stagnation where the technology is improving, higher definition endoscopes, better cautery, drug-eluting stents, but we're really just doubling down on current paradigms without really trying to understand cause. We do have a high failure rate. We call it refractoriness, and we have surgeries that are 50% successful or successful at 3 months, but these are not really good for the long run. We need more thoughtfulness and open-mindedness. Very briefly, this is just showing compartmentalization, which is the concept of breaking symptoms and treatments down into groups that, for example, a dorsal hump that we think about reducing hump, dental crowding, extraction, allergy, inflammation, anti-inflammatories. We're never linking all these things. Sinus pressure fluid must be antibiotics and fests. In reality, all these things are related. Small chin, nasal blockage, apneas, droopy tip, headaches, but we as specialists tend to break them down into just treatments and not looking at the big picture. So we're going to start by understanding the human facial skull to understand nasal obstruction and airway disorders. Septal deviation and turbinate enlargement are not just random events treated by conventional maneuvers. Well, they are, but if we want to treat them properly and efficient, we'll see they're part of a bigger picture of facial dysfunction. I have some history with non-human skulls. This is me as a resident at UC San Francisco, watching them intubate a gorilla at the zoo for where we were involved in a sinus procedure, just to show that I do have some non-human surgical experience. Speaking of which, when you look at the human airway versus a more primitive simian airway, like a chimpanzee, you could see that the chimp or simian airway is much more prognathic, and that humans, the maxilla and mandible, are much more retruded. And in a paper we did about 10 years ago, you can see that this has been a steady progress from our non-human ancestors 2.5 million years ago towards now, that the skull has been retruding and the nose has been extruding. What this causes is a change in the structure of the jaw and the maxilla. And what I see as happening is the gonial angle, which is the angle of the mandible in trauma terms, is becoming more obtuse versus a right angle. And it's causing some of the skull components to rotate. The maxilla rotates down. This causes rotation of the vomer, the ethmoid, the quadrangular cartilage, and slowly we are continuing to evolve. So here's some well-known people, and you can see differences. I thought this was an interesting picture of a couple side by side of how the jaw shape is affecting the nasal shape and the maxilla. And I believe a lot of what's happening begins at the gonial angle and is a progression of evolution. Perhaps this young man, who's a direct descendant of William the Conqueror, has had changes in the gonial angle over the last 1,000 years as he prepares to become the next William. What's happening? Musculoskeletal tone. So for various reasons, perhaps sexual selection, a lot of our dental colleagues think it's related to chewing, but our mandible is becoming less muscular at the time and is becoming more slender with a more obtuse gonial angle from a more right angle with a more hardy masseter muscle. So do we know why? Not really, but we know that it's happening. So what are the clinical consequences of this? One is a nasal septal deformity. Two is a jaw structure with a tendency towards mouth breathing. So when you look at this more obtuse gonial angle and apply gravity to it, this is going to stay open while this does not. He's more likely to have sleep problems than his wife. The first thing we'll look at is why nasal deformity why the shrinking skull causes a nasal septal deformity. The conventional view is that we don't really understand, that it's intrinsic to the septal cartilage. The L strut is ignored. We just go behind it. We add cartilage grafts to overwhelm it. Memory is what causes the intrinsic force to redeviate, and that septal deviation is not really related to sleep disorders. Maybe we should use bigger grafts, more sutures, more exposures, implants, or should we re-understand it? What's happening as these skulls evolve, though, is the nasal aperture is shrinking, even though the size of the ethmoid and septum are remaining the same. So what's happening is it's causing a crumple zone in the nasal aperture, causing the septum literally to buckle. So as the maxilla alveolar ridge rotates up, it causes the vomer to rotate up, which causes the ethmoid to rotate up, which causes the quadrangular cartilage to no longer fit. So it causes bulging here, downward pointing tip, and an overlap here, just like tectonic plates, where the septum cartilage and vomer and maxillary crest can't all be in the same place. So it causes a buckling of the septum. And we studied this as well, that what's happening is the septum is extruding. It's literally being pushed out. This is a normal septum, and this is an extruding septum. And you could see this is Mount Hood on its side. It is quite resemblant to a classic septal deformity, where if there's no septal overlap, it lays together with a nice aesthetic. When there's overlap, it causes a deformity, and internally, a buckling. So essentially, you have a normal septum, a vertically compressed septum, and a vertical and horizontal compressed septum. It's due to extrusion by the premaxilla that's forcing the septum out, creating a tension nose deformity. Another CT example of the normal aperture and the extruding aperture with the resultant short lip and tension nose. What it does also is by protruding outward, it narrows the nasal valve. So the nasal valve is not a collapsed structure. It's just like a tent that if you made the poles too high, it would look narrow. So adding grafts or implants out here doesn't help. It's actually shortening the septum. The L strut as well can affect the nostril shape, and it must be addressed. You cannot just remove the posterior septum. So the nasal septal position affects, just like a tent, the nasal sidewall. But the shrinking maxilla also causes the jaw to stay open at night, especially in low-tone states. If in a perfect facial skull for Homo sapien, the jaw, and this is just cartoon renditions, we have less mouth breathing because you have more tone. As we decrease tone with age or BMI, loss of muscle tone, and gain of adipose tissue, you have more of a tendency to even have mouth breathing in the day due to the unfavorable gonial angle. So as we increase tone, we decrease mouth breathing. Same thing, same model, is that now that gonial angle that's more obtuse versus the right one is more likely to hang open. So why does that matter to a rhinoplasty surgeon? Because the symptoms for nasal obstruction and nasal underuse are identical. They both feel the nose is clogged. But one is actually due to blockage and one is due to underuse, where all the breathing, the airflow that goes through the mouth causes the nose to fill with soft tissue of turbinate type. And the turbinates are not the actual obstruction, they're actually secondary to underuse. And this is why we have such massive inefficiencies and refractory results and are so confused, and our patients are so confused. So again, nasal deformity is a crumpling of the septum or iatrogenic, where success can be achieved. Nasal underuse is most common. It's due to obesity, large tongue, large turbinates, age, and chronic mouth opening. Gonial angle causes negative pressure to build in the nasal cavity and nasopharynx, causing the turbinates and adenoids to enlarge. But these aren't obstructive. These are secondary to lack of use of the nose. And that causes negative pressure to build up and why it doesn't work. So when a mouth breather has tongue collapse, the negative pressure from inspiration causes buildup of negative pressure in the nasopharynx, whereas in a positive airflow through the nose, the mouth remains sealed closed and there's a column of air. A graphic example. And when we did this model testing, we found that when we coated a tube that was a simulation for nasal oral breathing, when we blocked the nose, the latex mucosa grew exactly where the adenoids or turbinates would be in almost the same fashion, and you could see them growing. When we did flow dynamics, you can see that by improving the nasal valve and allowing someone to convert from a mouth breather to a nose breather, you massively pressurize the nose and change the dynamic of the airflow in the cavity to be less turbulent. It's just the negative pressure is generating pressure. The mouth breathing generates negative pressure on the pharyngeal walls. So the turbinate, this is the conventional view, is that inflammation causes it to block the nose, but in reality, inflammation causes the turbinate to grow extrinsically, whereas here negative pressure sucks the turbinate in, and it's a sign of nasal underuse, not a true source of obstruction. We tested some of this with thermal imaging to document this, but I'm not going to go into this today. It can be useful to distinguish nasal adequacy from nasal underuse, but that'll have to be something for offline discussion. Mouth breathing, because it causes the tongue to be unleashed, causes collapse as well. So how does tone, mouth breathing, and OSA come together? If OSA severity and tone are compared, the slope of the line as you have increasing age and BMI will increase your OSA severity. And these different lines represent different facial structures. So this is the best facial structure, and this is the worst. So someone with a weak chin and a crooked nose is an obligate mouth breather, and as their tone and BMI age and BMI increase, their OSA severity increases the fastest. And we actually have this from published data on nasal structure. This is probably the median, where as the tone and BMI increase, OSA severity increases more slowly, and this is the healthiest, perhaps a super athlete, where even with gains in tone, age, and BMI, a super athlete's skull configuration, the OSA severity increases slowly. But this is why childhood OSA, no matter which structure, tends to be very low severity. And this is someone who's almost syndromic, would be up here, and has a very rapid progression towards death. Putting it all together, this is the conventional view, is that we have these multiple things of bad luck, turbinate enlargement, septal deviation, valve collapse, that cause nasal symptoms, other unrelated things. But in this rethought view that's mostly from Christian Gamineau, is that the maxillary mandibular deficiency causes both septal deficiency and limited tone, causing mouth breathing, OSA, and hypertrophy of the turbs and adenoids. So which one of these guys is going to be more likely to see an otolaryngologist for nasal underuse or nasal obstruction? I'll let you be the judge. So the solutions: do we do minimally invasive things that are easy, shrink the turbs a little, take a little piece out of the septum, or do we do the super complicated open rhinoplasty, the 8-hour surgeries with tons of grafts that I'm not sure are even that much more successful, but they certainly make you think they are? The functional goal is to convert from mouth breathing to nasal breathing. The aesthetic goal is to preserve or slightly improve someone's aesthetics without making them look unnatural. Again, here's an algorithm of trying to understand nasal underuse versus obstruction. Evaluate someone's BMI. This determines it. Do they need jaw support? Do they need positional therapy? And only obstruction do we operate on, which is actually rare. So we have to make that correct diagnosis. The patient has an inability to keep the lips closed for more than a minute. That's true obstruction. When they can breathe, even though they say they can't breathe at night, but they can breathe during the day, they probably have underuse, especially if they're high BMI or older and never had the problem before. So obstruction doesn't just suddenly appear at age 50, but nasal underuse does. Why else do we avoid shrinking the turbinates? It creates eddies in nice flow. It creates a lake effect that it's really better to have work at the nasal valve or nostril, avoid the turbinate. We've already talked about the distinguishing of nasal underuse. I don't think there's an internal and external valve. I think there's one 3D funnel that is from the nostril into the nasal cavity. And they're really, it's how they're coordinated. You can't just dilate the nasal valve by shrinking a turbinate and ignore the valve, ignore the nostril. It's really how they're coordinated as one funnel. Talking about them as separate entities is what causes failure. If you think you can fix the internal valve without the external valve, you're going to fail. So surgical treatment, we all know the best is spreader grafts, but actually that's obsolete. These take up just as much space. If you see in my book, you'll see that actually decreases the surface area by fitting them in. Even a small spreader graft that opens it up, you can mathematically prove, even if there's evidence that they work, that they don't. So what do we do? I like to use what I call the rhinoplasty compass to make the right diagnosis. So when we talked about the septal extrusion, it can extrude in an anterior-posterior fashion, and it can extrude in a superior-inferior fashion, or it can extrude in both. So just like the points of a compass, north, south, west, east, and then north, northwest, someone can have a AP minus, SI minus, or a short retruded nose, or a long extruded nose. So APSI, this is the classic tension nose, or just AP plus. We make the diagnosis of what the aesthetic deformity is, then it can predict what kind of buckling severity is going to be on the inside. Of course, the APSI is most likely to be deviated. How do we fix it once we've made the right diagnosis? It's very basic. The approach is non-therapeutic, but it gets us to the overgrown septum. You can use an endonasal approach. Then we do release of the tension of the septum from the maxillary crest and ethmoid with care to preserve the keystone area. We resize the septum to get it to a neutral AP0, SI0 septum. We reposition it to the midline, and then we reinforce it either with the splints or sutures. But the sutures and splints are non-therapeutic. All they do is reinforce. Approach, release, resize, reposition, and reinforce. Or as I joke with my residents, the R, like pirates. Solution, we already talked about this. You find you have to release the caudal septum, and then you can shorten it, and it can improve airflow. So again, it's the opposite of a conventional septum. We don't remove this piece, we preserve it, but we release it, except for up here, and we excise the anterior and inferior in the AP plus SI plus nose. Again, excise to get it to normal size, and you see that deformity goes away and the septum goes to the midline. Here's a patient, my view is blocking it a little bit, but you can see we straighten the nose, we shorten and set it back, and the nostrils increase markedly. It also helps lip redraping. This is a video of shortening the L strut. I'll just...
and exposure are being used to reduce
shortening the L septum.
Caudal septum is reduced all the way.
This is just showing how to reduce an SI plus nose. Again, this is SMR, submucous resection, still deviated in the same case. But if we reduce the anterior L strut, it has a brand new straight L strut behind it. And because it springs to the midline, it works. So we excise here, here, and we separate here. And then you can remove bony septum. Here's the AP plus SI example using this modeling. It's overgrown, both too long, the septum. It causes a dorsal hump. It causes deviation, stretching of the upper lateral cartilage, and this is normal. Here's the SI plus AP plus compared to the neutral nose and the SI minus AP minus nose, just as relative. Here's an example where it's completely buckled. This is not intrinsically buckled, it's because it's too long, it's bowed. So when we shorten it, it swings to the midline. Same thing, and the nostrils are bigger. Makes a shorter, better bridge, but it's still appropriate. This is someone, same thing, but with sleep apnea, bulging, make their nose smaller. Here's the nostril improvement, better closure, and even with sleep, the AHI and REM is 34 to 9. Nose scores improve from 100 to 15. AHI improves from 9 to 2. Another one with CT findings. This is just her pre-op. Shorter, less projected nose, but massive improvements in airflow and in the biggest changes in the lip dynamics that allows her to be the mouth closed person. And here's the pre and the resized nose. Another examples, pre and post. I already showed you this one. Another example, and it's common in Mediterranean noses, too long, too forward. That's the APSI. This is really AP plus, because her nose isn't really too long, it's just too forward, but it makes a huge difference in symmetry and size. Very briefly, you can shorten this is the ALAR device I mentioned. You can shorten the distance between the lower lateral and upper lateral. This is not the point of this talk, I'm just giving an example of how you can coordinate the side wall by improving overlap while you're treating the main thing, which is the septum. This is a good complementary procedure. Then you use sutures and a splint to you suture them together and shorten the nose by pulling them together like a pulley. And this is a temporary splint, like a Doyle splint. This is a complement to the septal procedure. And that's how you cinch it down and tie it, and it shortens the nose. Better overlap here. put tape on. Other commercial devices, I can't see how beyond its time before it absorbs that it does much. It's mostly, again, a space occupying. Shrinking the mucosa possibly is helpful when you have excessive negative pressure buildup. But again, you're treating what's a sign of underuse, not treating actual blockage. You can use modeling to look at any procedure. So in summary, the shrinking Homo sapiens skull predisposes to mouth breathing in two ways: nasal septal deviation, but also poor tone settings to jaw relaxation because of mechanical unfavorability. Nasal underuse, jaw relaxation during sleep, is distinguished from true obstruction of the nose. And if you understand this, you'll have a lower failure rate because you'll know who you can fix and who you can't. But both aesthetics and function can and should be restored by even a general otolaryngologist who just has basic septoplasty skills. You can do all the approaches I showed through endonasal incisions, and you can be taught them very easily. It shouldn't just be the two extremes of the 8-hour rhinoplasty with rib grafts versus doing almost nothing with cautery or shaving type things. We all should be doing it all or nothing. Either do it, we should be doing it right, or doing nothing. So that's the talk from today. You can reach me if you have questions at hstupak@gmail.com. Thank you for listening and allowing me to talk, and enjoy the rest of the meeting.